My name is John Tesser. I've been a rheumatologist for 41 years, starting with my fellowship, which occurs after training in internal medicine. So after doing a residency in internal medicine, which I did at the county hospital in Phoenix called Maricopa County Hospital at the time. I started my education at Yale University as an undergrad, and I went to University of Rochester in New York for medical school. And that's when I went to Arizona after that. I did my residency in internal medicine, and then I went to North Carolina, and I did my fellowship in rheumatology, 2-year fellowship. And then I came back to Phoenix because I was asked to become the chief of rheumatology at the teaching hospital where I did my internal medicine training. And after 10 years of doing that, I went into private practice with a previous partner who had asked me to join him in 1992. And I was with him until 2004. And unfortunately, he died in 2004. So at that point, I had had some preliminary discussions with some of my colleagues and friends at Arizona Arthritis and Rheumatology Associates, and brought my entire practice over from what was Arizona Rheumatology Center to AARA. So I've been with AARA for the last 17 years. Patients come to see rheumatologists because they have either very directed and focused musculoskeletal complaints, back pain, joint pain, neck pain, muscle aching, those kinds of things. Or they may have some systemic symptoms that might suggest that they have a systemic autoimmune rheumatic disease. Now, that's a very important thing to try and distinguish. But in terms of taking those symptoms that a patient has and then doing a proper physical exam to understand what the physical findings are and to meld that together to get a picture of what the patient's overall problem is, allows a rheumatologist to then focus on what the plan is to help the patient not only feel better, but for some of the diseases that we take care of to prevent damage. So when we see patients, the primary point that we need to achieve is to understand very quickly, are we dealing with an inflammatory joint disease or an inflammatory systemic disease or not? Because if it's not that, then we're probably dealing with either degenerative osteoarthritis issues of peripheral joints or back or neck, or possibly soft tissue rheumatism like bursitis, tendonitis, ligament problems, and this kind of thing, biomechanical pain. And it's very important to segregate these things out to try and get a whole picture of what is ailing the patient. Understanding that, one has to appreciate that a patient may be coming to you who may have a number of different things. They may have rheumatoid arthritis, they may have trochanteric bursitis of the hip, they may have neck disc arthritis, all of which are not necessarily related to each other specifically, but they're in the same patient. So that's important to understand because in order to help the patient, you have to address each of those things. And I try to explain these things to patients right off the bat so they have a clear understanding of why we're going to do the tests we're going to do, blood tests, urine, imaging of x-rays or MRI or bone density for osteoporosis. And that gives them, I think, some confidence in knowing that I know what I'm talking about, I know what I'm doing, and I'm going to direct them on this journey to get them to a place where they will feel better, and also to understand if there's a potentially damaging disease, we're going to try to get on top of it and to control it. We've had a very interesting history in our field because rheumatology can be divided into two periods, the pre-biologic era and the post-biologic era. And the biologic era refers to the advent of those medicines which are known as biologics. They are infused or injectable proteins that have been developed to target very specific items in the immune system, whether it be the cells or the way the cells communicate with each other, via the way that they directly communicate together, or how they produce and release signaling molecules called cytokines. Many of the biologic medicines that we have directly block those cytokines. So, much like an army, the immune system is composed of generals who create the orders, and they send their orders to the foot soldiers, fighting cells, at the site of inflammation that can lead to damage. And they do this by producing these cytokine messenger chemicals. So if we block the orders, the foot soldiers don't fight, and we can thereby downregulate the inflammatory disease. And in fact, what we are attempting to do there is we're attempting to rebalance the immune system more towards normal. So the advent of this period was 1998, when the first biologic medicine was approved by the FDA. It was called Enbrel. And subsequent to that, we have between 15 and 20 molecules, including the biosimilars, which have been developed to be extremely close to exact as a protein can be to the originator, but not exactly the same as a generic, which is a molecule that is exactly the same as a small pill, if you will. Prior to 1998, we had a number of small pills, but not too many that were really what we would call disease-modifying anti-rheumatic drugs. We only had a few of those. Methotrexate, leflunomide was only identified and approved in 1998 itself. And before that, we were in the dark ages. Rheumatologists were using a ton of non-steroidal anti-inflammatory drugs. Most people understand these as being the ibuprofen or the naproxen in Aleve, and the other 28 or so that were developed during this whole period of the 60s and 70s all the way up through the 1990s. But also we had medicines which we don't use anymore. Gold injections, which were a mainstay of treating rheumatoid arthritis. We had penicillamine, which was a pill that we don't use anymore. You can't even almost get it anymore. We've used hydroxychloroquine, an anti-malarial drug, for many decades since the 1940s or 50s, because it was found to help people with rheumatoid arthritis and lupus. But these were the dark ages for rheumatologists. We were waiting for science to do its work to further allow us to understand the cellular elements of the immune system and then these cytokines. And once all of that detailed work, basic work, was done, it allowed the clinical scientists to develop the new medicines that we have. So a lot of my career has been focused also on clinical investigation. And Arizona Arthritis has been doing clinical investigation for its entire history. We have been so involved in clinical investigation that all of the physicians in the group, myself included, have actually worked on every single drug that has been approved by the FDA in rheumatology. And there have been many, many of these. As I said, there's between 15 and 20 biologics, and now we have new medicines for which are pills, targeted small molecules, things like Xeljanz and Rinvoq, among others. So we're very proud of that work because it has helped our patients to have the availability of participating in those studies and then ultimately developing the ability to derive benefit from the medicines that get approved and on the market. The premier autoimmune rheumatic disease that we deal with is rheumatoid arthritis. It's an autoimmune disease. The focal point of the imbalance in the immune system are the joints, the lining tissue of the joint called the synovium. But unbeknownst to most lay people, it's a systemic autoimmune rheumatic disease. And as such, it actually can cause a lot of inflammation and damage outside of the joints. We call these comorbidities. Each of these diseases has their own particular characteristics of which part of the immunologic system is imbalanced, which cells, which cytokines that are signaling, which cells are doing the fighting, and which organs and which parts of the organs are being targeted by the imbalanced system, where the focal point of inflammation is. In rheumatoid arthritis, as I mentioned, it's the joint tissue lining called the synovium. In psoriatic arthritis, interestingly enough, it's the attachment of ligaments and tendons to bone. It also can allow for synovitis, inflammation of the joint tissue. But that's the focus of psoriatic arthritis disease. And it can involve the spine because the spine has a tremendous network of ligaments that encase all of the vertebrae and go right up from the base of the spine to the top of the spine in the neck. And all of those ligaments are at risk to be attacked by inflammation as part of either psoriatic arthritis or a related condition called we used to call ankylosing spondylitis. Now it's called axial spondyloarthritis. So patients with these diseases are at risk for early mortality, heart attacks, strokes, heart failure, atherosclerotic disease. There can be inflammation in the lungs that leads to interstitial lung disease and scarring. For some of the diseases, like lupus, there's an attack on the kidneys in some patients, which can lead to kidney failure. These diseases, because of the systemic chronic inflammation, actually put patients at risk for cancer. So one of the difficult challenges we have is when we're using the very powerful medicines that we use, biologic medicine, targeted small molecules. We appreciate from studies that some patients develop cancer while they're on the studies, but we have to understand that the diseases themselves may push people to cancer. Maybe our medicines are doing it. And we have the challenge that we've approached over the last decades trying to figure out what's causing what, and is it safe enough to use the medicines? Now, the thing about our diseases is that after pain, the second most common symptom is fatigue. And fatigue is a manifestation of systemic inflammation, but also chronic pain. And it can be very difficult to deal with fatigue in patients. We see a lot of patients who come to us because their doctor has taken their symptom of fatigue, maybe some kind of pain that they have, and run some tests for screening tests for lupus or rheumatoid arthritis. And if any of those are positive, they say immediately go see the rheumatologist. The challenge there is that any of those screening tests you will find in normal people 5 to 10% of the time. If I dragged 100 people off the street, I ran a rheumatoid factor on them, a lupus ANA screening test, 5 or 10% of them will have a positive test. Everybody who comes in here with fatigue may think therefore they have one of those diseases. And it can be very difficult to have that conversation with a patient and explain, no, you don't have that. And it's kind of interesting because you would think all the time that a patient hears you don't have lupus or rheumatoid arthritis, they'd be jumping for joy. And that does happen a lot because a lot of them come in and they're scared. But sometimes it's, oh, then what's wrong with me? And that's a very difficult, challenging position for the rheumatologist. You don't want to ignore that, and you want to explain to the patient there may be other reasons, other factors that come into play. And some of these chronic pain conditions, like fibromyalgia, can be what's at hand, and then that's another whole discussion of someone who has chronic musculoskeletal pain, fatigue, they have non-restorative sleep pattern, and they may have tenderness all over their body, which is the constellation of what fibromyalgia is. The key there, it's not a systemic inflammatory disease. It's not an inflammatory disease at all. And it's very important to explain that to the patient because without inflammation, there's no damage. And if there's no damage, that is the saving grace. But there are approaches to try and help patients deal with these issues without medicines, using mind body disciplines and things like that. So it's very challenging dealing with patients who have these terrible diseases because then you have to walk them down the path of, we really have to go towards these powerful medicines. Let me explain the benefit to the risk ratio there, which is, by the way, exactly how the FDA looks at medicines when they consider approving them. Though actually they look at it from the opposite point. They look at the risk to the benefit ratio because they're primarily a safety agency, right? But we look at it from an efficacy to risk ratio, because basically a drug shouldn't be approved if it's not effective. But then you have to clearly identify what the risk is in terms of safety. And that may differ for different patients. And so we have to deal with that. So we have to walk the patient down through that. But the idea is to give them hope and understanding we're going to be there managing it, managing the risk, but getting the benefit. Well, the other challenge is we don't have tests to tell us what medicines to use for patients. And that's one of the holy grails of our specialty. We need ways of identifying which patient will respond to which drug. And we're not there yet. We're getting closer, but we're not there yet. Other disciplines have some of that. In oncology, they have some of that. They have these markers. So for us, with our patients, unfortunately, a lot of it is trial and error, walking down one medicine after another until you find the right medicine. When we're dealing with systemic inflammatory rheumatic diseases, we understand that the inflammation has effects on all of these other systems. The neurologic system, we have to deal with peripheral neuropathies or central nervous system inflammations, where we have to deal with vasculitis. There's a whole family of rheumatic disease known as vasculitis, which are inflammatory blood vessel diseases. Imagine that. Blood vessels get inflamed on a systemic basis because the immune system is imbalanced. Any blood vessel, anywhere in the body, can be affected. So we have to understand all of these different organ systems to be able to appreciate how to identify those comorbidities and to also appreciate how to approach treating them, in addition to treating the joint disease. And we have to collaborate with our specialist colleagues, our pulmonary doctors, our neurologists, cardiologists, our nephrologists. Every day we're on the phone or we're sending notes to all of these people. It's a very fascinating but complicated business. And rheumatologists have this reputation of being known as an internist's internist. When an internal medicine doc or one of these other subspecialists can't quite figure out what's going on, they kind of turn to us to try and put it together. And a lot of times that's the right way to go. We do put it together. I want to point out there's another very important aspect of rheumatology that many or most rheumatologists particularly focus on as well, and that is on bone. So we identify, diagnose, and treat osteoporosis in all of its various manifestations. There's normal bone density, which helps to contribute to normal skeletal strength. Young people don't break bones unless they have major trauma. Old people break bones from minimal trauma. We consider off the bat someone who breaks a major bone, arm, forearm, hip, vertebrae, pelvis. If they break a bone like that from a fall from a standing height, we assume that their skeletal strength is not good. They're weak, unless proven otherwise. That immediately should trigger consideration of getting a bone density study and understanding what the skeletal bone mass is. Because like any structure, The strength of the structure is related to the amount of material and the microarchitectural integrity, engineering principle, if you will. And as we get older, our bone density starts to drop and the microarchitectural quality of the bone starts to deteriorate. Interestingly enough, we all start losing bone density about the ages of 25 to 30, which, by the way, is the same age at which we start to lose kidney units called nephrons, about the age of 30. So as our bone density drops, our skeleton becomes more fragile. Now, some people are much more at risk for this happening, and it happens more quickly, particularly in women after the menopause, because estrogen is protective to the skeleton, and when women go through the menopause, they lose their estrogen, and some of them have dramatic drops in their bone density, or it's more gradual. And men lose bone density too after the age of 50. It's more gradual though. So they will suffer osteoporotic fractures at a later age generally than women do. But for any adult after the age of 50, falling down, breaking a major bone, we have to think that they may have osteoporosis. Do a bone density, and we can see how much lower is their bone density in their hip, their spine, possibly their forearm, compared to a normal bone density person who is at age 30, as I mentioned before, right? So consequently, we use the standard deviations against the average bone density, and that's called a T-score for people who are after the age of 50. But what's very important to know is that if someone who is in their 60s or 70s, maybe late 50s, if they've broken a bone, that by definition is osteoporosis. You don't need a bone density, a DEXA, to diagnose it. You get one to understand what the level of bone mass is, but you already know what's going on. And the reason why this is so important is we have good medicines to treat it. We have medicines that can increase bone density and ultimately increase bone strength because they also improve the quality of the bone, that microarchitectural engineering principle. Up until 1994, we had no good medicines to treat osteoporosis, none. Calcium, vitamin D is important, but that's like breathing air for bone. That's not enough. Exercise, very important to get anti-gravity principles against the skeleton to help improve the skeletal strength, but not enough if someone has significant osteoporosis. So we actually have the pre-bone active medicine era, pre-1994, and then the post-1994 bone active medicine era. And we've had a number of very good medicines that have been developed over the years for that. So rheumatologists are very good at this, and they're very interested in this. And you can see how it flows very importantly into the rest of what we do because we're musculoskeletal experts, and musculoskeletal includes the skeleton. So fractures are, we don't repair fractures, but we help to improve bone density and we help to prevent fractures. And when fractures occur, pain occurs. And if there's malalignment, or even if there's normal alignment and the healing of the skeleton happens, there still is unfortunately opportunity for ligaments, tendons, muscle strains, and tears to occur, trying to support these weakened structures. And that can lead to chronic pain too. So I hope I've given you a picture about the history of rheumatology, my history, the history of diagnostics and therapeutics. But as I say, many of us, my colleagues will say, a medicine and therapeutics is only as good as the effectiveness of the drug and the medicines that you have, the safety, but the access. If the patients don't have access to the medicines, it doesn't help them. It becomes very important for a rheumatologist to work within a system that has established itself with proper organization, departments and divisions to be able to offer access to the medicines and therapeutics to our patients. It has taken Arizona Arthritis and Rheumatology Associates many years to get to this point where we have achieved a major level of success, a success of our operations in our organization that is recognized locally and nationally. And in fact, we are probably the biggest private practice of rheumatology clinicians in the country because we have 15 rheumatologists, 30 advanced practice, at least 30 advanced practice clinicians, 45 clinicians, which is huge. But we also have our departments. We have our department of imaging. We do x-ray. We do bone density. We have our ability to send out our patients for MRIs. We have our department of laboratory drawing and laboratory processing for all of the 8 clinics in the state. And we do all of our own laboratory processing. We draw all of the patients here, regardless of whether the payers pay us to do it, because it's more efficient, effective, and we don't miss. Send patients out, they may not get it done, et cetera, et cetera. We deliver our infusible drugs in the office. In all of the clinics, we have infusion centers, which affords the access of our patients to get the medicines that they need. We have very specialized departments to go through the tedious, odious, unfavorable responsibility of getting the prior authorizations for patients who need infusions. We have to ask the payers, will they pay for it? And for the patients who are doing self-injections, where we don't deliver it, we can't because it has to be done at home. But we have a department of people who goes through that prior authorization. And for the very specialized small pill authorizations. These departments in our organization have been so finely tuned and work so efficiently that we are able to get our patients who need these therapies as soon as possible, ASAP. And I will tell you that in describing our operation to my colleagues, and I have a lot of interactions with national and even international rheumatologists, and they are truly amazed at the capabilities that we've developed in our operational procedures and elements of organization. So this is key because at the end of the day, we can diagnose our patients very well. We can send them to physical therapy, but when we can deliver this level of service of diagnostics, lab, imaging, and therapeutics, as I mentioned, this is at the highest level of medical delivery I think that we can achieve.